tonight we have a very special guest. We have Dr. Hollis, who is a colorectal surgeon at the Division of GI Surgery at UAB, where I am lucky to be his fellow. He is a native of Dothan, Alabama, and Dr. Hollis completed his undergrad at Washington and Lee University before coming back to Alabama for medical school at UAB. He stayed at UAB for general surgery residency, and then during residency, he dedicated 2 years to training in outcomes research and obtained a master's in public health at the UAB School of Public Health. Following residency, Dr. Hollis completed a colorectal surgery fellowship at Cleveland Clinic, and Dr. Hollis's clinical practice includes the breadth of colorectal surgery. He has specific interests in hereditary colorectal cancer, inflammatory bowel disease, and colorectal cancer screening. And the research that Dr. Hollis performs aims to increase the adoption of interventions that improve colorectal cancer outcomes and ostomy-related care. And tonight, he is going to talk to us about transitioning to practice as part of our Transition to Practice series for all of the fellows out there, and specifically setting up your practice. So with that, I will let Dr. Hollis take it away.
All right. Thanks, Stevie J. Excited to be back on here. I don't have any disclosures regarding my talk. So I am in academic surgery. I have half a day of clinic a week, a full day OR a week, right, 2.5 days of research, do endoscopy, go out to a rural medicine clinic. But I guess the point of showing you this is I try to make this talk applicable to anybody, whether you're going into a community practice or you're going to be heavy into research. Hopefully you'll find tidbits here that can be helpful for you starting out. I've roughly organized this into just getting started, what to do in clinic, how to handle the OR, building a referral base, and then some tidbits on academic medicine. I'll probably talk for like 25 minutes, but hopefully during this time you can like develop any questions and we can direct those just to get you thinking. This is an exciting time. I've got 2 more weeks left in fellowship. I completely remember this time. It was really, it's like the end of this long journey. And well, there have been like very clear railroad tracks going forward. The tracks are sort of ending, and now you're equipped with the skills to go out on your own. It can be a little daunting. But there's practical things that are going to happen in this next few weeks. Is you'll be done with fellowship. You'll have to move. You'll have to get settled at a new home. Many of you may take 4 to 8 weeks and relax, and it's very well justified. Here's my wife enjoying a White Claw on the Gulf Shores beach. Here's me taking my kid to a water park on a weekday, which was all great. And I think it's good to take this time to look back and appreciate all that you've done. So take the time to completely unpack, to organize. We actually use the time to do a little bit of financial advice or meet with financial advisors for budgeting, set up some disability insurance. And then I also use that time to like reflect, like, all right, wow, I've accomplished something amazing, but what do we have going forward? What do I want to accomplish in this next year, in the next few years from a clinical research service standpoint? And since I was going to academics, I also had to spend a little bit of time thinking about the types of aims that I was going to be writing and applying for grants. Inevitably, that first week in your job is going to come, whether it's 4 or 8 weeks later. And many of you will be in an office, look very bare, and definitely spend the time to go ahead and get it jazzed up to your standards. My office has not changed since I first put it together with my wife right after we got started. I accumulated a lot more dust in different corners. But I've had some advice that was given to me to go ahead and make sure all of my like training, all those health streams, whatever it is, get it all done there right at the beginning so you can focus on other things. I was given also advice to sit down with my IT people at my institution because it may be very different from either if you're going back to a place you were, it may have changed, but to understand like how can you set up computing that works for you, that's seamless between what you're doing in the clinic, in your office, and at home. And how can you best utilize file storages? Like, am I supposed to use ShareFile or the box? Where does my research get stored? How can I best organize files so that I have a good system for years to come? getting acquainted with your EMR, getting your dot phrases in there, setting up the clinical apps on your phone, and updating all the university websites with your, or practice websites with your information. Take time to get that done so you don't have to worry about it later. And then lastly, in those first 2 weeks when you're like sitting in your office, like, what is going on? Like, I used to be like going 100 to nothing. Now, like, waiting for things to get going. It's a great time for you to start meeting with some stakeholders. If they are specific GI people that are in the IBD that you really want to interact with, or specific oncologists in GI, meet with them. And also meet with other people in your practice or that may be adjacent to your practice, the HPB surgeons, or for those in academics, meet with other junior faculty under similar career paths to know what has worked, what hadn't worked for them, where your resources lie. Also found it particularly helpful to know who else is starting with you. So if you have a GI or a gyne or a urologist starting out with you, going through all those training courses, you got to fit together in person. They can be great contacts as you start to develop your practice and need help in certain situations. All right, let's jump in. Setting up your clinic. It's really key wherever you're going to understand what the clinic culture is there. And nobody knows this better than the clinic manager of how best to run your clinic. And also, like, what is the actual workflow for your place? Like, how do people get scheduled? Like, you got a new patient, you send it to your nurse coordinator. How are they actually getting an appointment made? At UAB, it's very different. We have an access surgery schedule center that's different, and I never see these people. But I need them to know what my preferences are and how do you communicate with them. I put on here, like, what's in the cabinets? What do you have available? I remember my first week in clinic, I was trying to figure out where the iPads were because I had to consent somebody. And I thought they were in one cabinet and had a code on it, but I didn't really know the code. So I just pulled really hard and like broke the wood off the cabinet. And I found that that's where all the nurses store all their purses. So they always remind me that they can't secure their purses in that cabinet anymore. But nonetheless, I figured out what's all in the cabinets, where the silver nitrate is, et cetera. Is it typical for you to be able to do flex things in clinic, or is that not something people do? Can you remove metaports in clinic or not? What is typical? Meet and learn the culture, and then additional needs. So I do a fair amount of rectal prolapse surgery, and I always in fellowship learned to examine people with a bedside commode in a mirror, which is really great. I was always going over to my urogynecology colleagues for the first several months as an attending, and finally my clinic staff when it got me a bedside commode to have in our clinic. So you'll be asked to set up a clinic template, is my guess. I am not good at setting up clinic templates. I'm probably in my third or fourth clinic template. And probably my number one complaint of my patients is that I was late to their clinic appointment. And looking at this template that was one version of it, I see that all my news are still 15 minutes, just like every return and post-op. So that's probably a problem. So the best way to do this is ask what your partners are doing and what works there, because that will help and guide you. And you also have to select a diagnosis list. Like, what are you willing to see? I put everything. As a new faculty member, I was willing to do all of colorectal surgery. Maybe later on in my career, I'll narrow down, but I'm going to be a team player unless I'm told otherwise. And then start thinking about clinic efficiency. How can you prepare for clinics? How can you set up notes so that you know what's going on? There's a whole nother talk to understand on billing. That will be important for you. But also think about how can you set up routines where charts can be closed the same day as your clinic so that you can move on with your weeks. I have a few pearls throughout this talk, and this is like pearl number one. And this came from last year's version of this talk, which was a little panel of us, where we said it's okay to tell a patient that you need to discuss their case with others before the next step. So inevitably, you're going to have a clinic where it's packed, and they're going to add on some new patient with a weird diagnosis like anal melanoma, and you're not going to know exactly what to tell them as the next step. It is perfectly fine to tell patients, I need to go talk to more people and figure out a good treatment plan for you, and I'll call you later in this week. Patients actually appreciate that because it means that you're caring or spending more time on their care. Working with the nurse coordinators can be new for most of you. I'm sure I've interacted, throughout your training, but having somebody dedicated to you is new. Real important to sit down with them during that first week, during that slow time. And during that first meeting, what I would encourage, if they're an experienced nurse, I would encourage each of you just to listen and say, tell me about what it's like being a nurse coordinator and what your role is. and tell me about what has worked, what hadn't worked. Tell me about your preferences and how can we make the best practice. And then after that, then you could perhaps share different ideas you've seen that have worked. I think one of the key things in that conversation is to define communication and how it's going to happen between you and your nurse coordinator, because that's what's going to make a really successful relationship. I mean, these people are your number one ally in patient care for outpatient setting. For my nurse, we actually communicate through the EMR for the majority of our requests. It gives us a good trackable thing. And if she's out, other nurse coordinators can see the paper trail of what our discussion was. But certainly if more urgent things come up that I may not see in the EMR while I'm operating, she'll text me, and really urgent stuff, she'll call me. And then like scheduling stuff, do we need to close the clinic? We'll get emails. She knows she can contact me at any time, after hours, whenever. But I respect her and I don't contact her after hours. I'll figure out what I need to do going forward. And then we also have purposes for, like, if I'm going out of town, I'll find one of my partners and give them a heads up so that she knows she can message them freely if people need opioids or other patient concerns going forward. Know that training takes time. So this is one of my learning points from the year or from the past 4 years of my practice is that when I first started out, I was very eager. I was like, they would send me a message like patients contacting you for nausea and vomiting at home. I would immediately go call the patient myself, and then I would, handle the problem and then respond like, hey, I called the patient, problem handled. But what I've learned as my practice has evolved is that it's actually important for me when I message back to say, hey, I called the patient. They were actually tolerating food and passing gas. So what we decided to do is back them down to liquids for a 24-hour period of time and make sure they can regress. I told the patient if they don't improve, they may have to come to the ER. By informing my nurse coordinator that, it helps equip them for these calls in the future and reduce my call volume long term. Just know that takes time. It's going to take more effort, but it's definitely worth the effort going forward. And then realize there's other team members, maybe schedulers, clinical medical assistants that help get records. Like, learn who those people are in these first few weeks when you have more time.
Quick question related to that part. So when you're setting up your practice, you're talking to all these people and you're thinking about like how you're going to manage your clinic and these phone calls. Did you have a system going into it where you were able to keep track of all of your like follow-up needs with patients? Like, oh, we had this tumor board meeting and I have to call the patient with this update. Is that something you also use the EMR for, or did you kind of have a separate like task list?
Yeah, that's a great question. How do you make sure patients don't fall through the cracks? I pretty routinely use my EMR messaging as a task list for those patient needs. I won't delete the message to me until I've handled the problem. I live my life by like an inbox zero policy. So if you look at my impact, my messages are completely clean right now. But if I get new messages, it's a to-do list. So, but it is important. And that's something you could talk about during that meeting. There are systems in each EMR to set up reminders. If somebody needs a colonoscopy in a year, like how do you, and you really want to make sure it happens. Like, can you actually set up a clinical reminder? And who is going to follow up on certain things? So those are all important strategies to outline. And feel free as more questions come up. Sometimes I speak too fast. Preparing for the OR. Similar to clinic is you've got to figure out what your local culture is. And again, it may have changed since if you're going back to the institution that you previously were at, or it may be in a different setting. Know who the key players that know that culture are. Typically your team leaders, they've been there for a while. They know who all the players and all the staff are. Also, if you have any assistants, RNFAs, PAs, you can get them out to a meal and you can talk to them, ask them, what works, what doesn't work. Give me examples of people that you really admire and like, why do you admire them? And like, those are things that you can learn, like what helps run and drive the OR forward. How do you get to be a true team member with all of them seamlessly? It's also good that you can stop. You don't have to go watch somebody's whole case. You've already been through training. You know how to do these steps. But it's often good to stop up when your partners are, say hey to them, to say, I'm just trying to learn, how things are coordinated around here. I'm going to look at your back table, understand what all you've opened for this case, sort of see the tools that they're using, what you have available to you can be really helpful. I think it's really good to know what resources you have. So I actually walked through all of our supply shelves. And you'll discover cool things like these little tiny ports with balloons on them for really skinny people. And so it helps to know what you have available. You can open, late in the afternoons, you can ask your team leads to open up the basic, A and B trays. So you know what's in there. I know if I go to Highlands, I don't have any Babcocks in my A tray. So I got to ask for them. Highlands is just another hospital across the street for us that we operate at. What retractors do you have and do they work? And so, you want to know if you get into pelvic bleeding, do you have that special thumbtack available, and, what brand, what variety it is. So you're ready to go. And then I think a lot of you in your fellowships are probably going around taking pictures of pick list and different tools. I think it's good to have that available for you, but also know, like, what are your partners using? When I started, when we were up in Cleveland, we used a bowel flora for a lot of redo pelvises, and it was just sort of an old standard used by many people. And when I came to UAB, everybody was using a Bookwalter standardly. So it wasn't hard for me to switch my practice to go to 100% Bookwalter. And also understand that there's some things you may want and need, but you don't want to be too needy. Fortunately, I had a partner that had come just a few years before that had gotten lighted anorectal retractors that I really wanted, and he got Fazio pelvic retractors, so that's what I loved. I only asked, so far I've only asked for 2 additional tools, which were this Bright Track, which you see there in the middle with the blue handle, and a Bainbridge, which is this straight bowel clamp. It's really the only 2 tools that we didn't have, that didn't have anything that did the same thing. And so I've appreciated that. But I've also adapted my practice, like these ostomy rods. That's what we used 100% in Cleveland. I had, within the first 3 months, somebody with an ischemic ostomy from an ostomy rod, a complication. So I've adapted using a red rubber, like one of my other staff members does during that time. So be flexible, but be knowledgeable of what you have at your institution.
And with that, did you feel any pressure to just use everything that was already there and kind of not do things the way that you wanted to do things when you started?
Not too much pressure. It was good that the OR techs knew the tools that they previously had, where it was, where to get it, how to set it up. So that was probably the bigger thing for me adapting, because I could ask for it and they knew exactly what I wanted. And that's sort of like going into your first OR day. Yeah, you are going to do some things different. And I think and you're not going to have preference cards. I wouldn't even try to establish a preference card beforehand. Perhaps you can get one of your partners to know what's going to be available to you. But I would just tell them, I would email them a list of, like, this is how many ports I need. These are all the tools I need. This is the suture I need to complete this right hemicolectomy. And they appreciated that. I think the teams avoiding that confusion can be very helpful. I think it's good in your first several months, avoid overbooking. You don't make friends by keeping people late at nights. And if you have a really hard, like, redo intercutaneous fistula takedown, maybe you set aside a whole day for it, even though you probably could sneak something else in, but maybe you just do that. And that will help the OR build trust in you going forward. Ultimately, you'll overbook sometime, but it's not a great practice at first. And then if you want help, know what's going on with your partners. So I have a screen on my EMR where I can see each of my partners' schedules. And if I have a complicated case where I want them to be just around and available if I needed help, I'll make sure I have it on a day where I see somebody else operating. Or if I actually want them to be in there with me, that's like a whole email chain communication, like, will you be there this day? And even in the days I want them to just be available, I'll give them a heads up. Hey, I'm doing this complicated case. I may ask for your help. Sometimes it's just a text. Calling for help. All right. This is such an important topic, and was the main discussion of our panel last year about transitioning to practice. So pearl number 2 is expected that you will ask for help. And I think it's on you to know who you're going to call. So I actually want to step through a few ways that I've asked for help in the past few years, just so it becomes normal for you in your practice. One example is a simple case, or not a simple case, but like a recurrent rectal cancer. We're really trying to determine, is this resectable or not? What's the next step? This case I'm thinking about, I discussed in MDC, but not all the surgeons were on there. A few were, but I really wanted the whole group's opinion. So I actually reached out even after MDC for additional opinions, and know that that can be fine. You just want everybody's input. I've had a pre-surgical mass in the past year and a half that was like extending to the intersphincteric space, and I wanted to do it robotically. But I think some people would probably argue that it needed to be done transcoccygeal or approach. So I actually emailed two other robotic surgeons and said, I really want to do this robotically. Is that reasonable? And they said yes. But I made sure I had somebody that's more familiar with the transcoccygeal approach available that day. I was starting to do robo-transanal excisions while I was here. I wasn't really familiar with tips and tricks for it, so I actually asked a partner to be there on that day that I was doing it. I do general surgery calls, so I remember a case with gangrenous cholecystitis that was I had a fenestrated cholecystectomy, had a persistent bile duct leak afterwards, even after an ERCP. So that's getting really complicated, way beyond my field in colorectal. So I was able to reach out to one of my HVP colleagues that I've become friends with, and they actually took over the management of the patient and got him a metal stent that worked out really well. And other times you just have to call, you just want to call somebody just to know, like, it's okay to do what's right. This is a case I'm thinking about, was an LAR DLI that was leaking in the recovery period. And even though they were diverted, they remained septic and had this large amount of stool still in their colon. And I ultimately had to take them to the OR and give them a permanent colostomy. So I'm in the OR looking at this, and the call department is like, I know this is what I got to do. Just tell me that I'm right. And it gave me the confidence to proceed forward. Other times you need physical help. So I had the case I'm thinking about is an anterior rectal tumor that was not really invading the prostate at all, but really just involving the seminal vesicles. So this is where I load the boat at urology, but also got another one of our colorectal surgeons to come in and look and make sure they agreed with our plan and approach. So yeah, pearl number 2, know who you're going to call.
I have a couple questions, some from the chat.
Yeah.
So when you were first starting, do you felt like you were calling more like the people that you trained with in fellowship, or were you calling your partners?
Great question. To be honest, I called my partners. It helped establish rapport with them. They knew what I was doing. I knew that they were going to be my backup. I'll be honest, I mean, like in M&M, they're going to be there with me, like holding hands with me. Have I called the people who have trained me? Yes, I have, especially for people for cases of their expertise, specifically like robotic ventral mesh rectopexy cases. I've asked for help from somebody from training, or for certain hereditary colorectal cancer cases, I've asked for help.
And then this is from Dr. Catley here. How do you suggest approaching institutional culture about positioning for proctology cases? For example, if you would prefer prone, but the institution prefers lithotomy.
Yes. Yeah, that's a good one. It will certainly be something that you have to feel out. You may find that your population changes. So like at UAB, compared to where I trained in fellowship, at UAB, we have a lot of obese patients, and they just can't, I mean, it's hyperventilation. They can't breathe in prone position half the time because of their obesity. So I pretty much have done to complete lithotomy for those cases. So there's a little bit of filling out patient population, the culture. Are you willing to try a little bit of lithotomy? But if it's not working, you don't feel safe doing it, then I think you tell the team that. It's like, I do this case best in prone.
I like that. That's a good way to say it. And then also, could you speak about the proctoring period that you underwent? I know it's a little different at some institutions, and just kind of what that was like and how you managed that.
Yeah, like robotic proctoring?
Or just if you have to be proctored for cases. Like I know some places you have to be proctored for like 5 scopes, 5 lap cases, or robotic cases, 5 open cases, and what your experience was with proctoring.
Yeah, so we didn't have any like direct supervision or attending proctoring. But I'll tell you who's proctoring you is all the OR staff and all the PAs, RFAs, anesthesiologists. They are proctoring you whether you know it or not. And that's how the division directors get their feedback because they're in the IOR. They're like, "How's Bob doing?" And they'll share everything. So I did do robotic proctoring. I had to do that at the practice. And so I would have one of my partners come in and they look and leave most of the time.
Okay.
But all right.
I hope that answers your question.
Uh, Dealing with complications. All right. So you're all going to have complications, right? If you operate. And they happen a lot in colorectal surgery. And know to load the boat when tough things occur. So this is, I think, some UC patient on a ton of steroids, had very delayed surgery with a big fascial dehiscence. There's that adage, right? For patients with these bad complications, they're the first you see when you arrive and the last you see at the end of the day, and it's totally true. I agree that abandonment is a huge patient fear, and it's tough to walk into these rooms when you've had these complications. But I've always felt better when I walk out of the patient room. Always be there for the patient. Um, and then overcoming imposter syndrome. So I think it's always important to talk to your partners when these things happen. I mean, sometimes they're inevitable. There's nothing you could have done different. And you know that. And I think it's good to just share that you've had these experiences. And certainly when I've had really drastic complications, I've talked with a lot of people just so they know that it happened and that what I'm doing about it. And then we'll talk about a case log here in a second. But important in loading the boat. CJ has seen this. I had a recent patient, this is 4 years in my practice, had the wildest complication 2 weeks after a standard robotic right hemicolectomy where they completely thrombosed their SNV. And they got transferred back to UAB. They were like septic, like near septic, but then they started clearing their lactate. And we were like, the treatment for this is really anticoagulation. I don't think his bowel's dead right now. But then I said, this is a bad complication. And I loaded the boat. We actually got a vascular surgeon on board just to give some more input. And when they went around as a second time during the day, the patient was getting actually more tachycardic and lethargic. And this is after I'd seen him, and they actually offered to do an SMV thrombectomy. I didn't even know that was a thing. And so it was only because I had loaded the boat. And when eventually we took up the patient to the OR, they thrombectomized the SMV, and the patient has unfortunately never lost any bowel, though we were very worried about him. But it's never a bad thing to load the boat. We'll go on to case log, because I think this is actually really important for imposter syndrome. And this is an example of what my case log looks like. This was given me as advice from my current division director, that these are the only variables in an Excel that I keep online in a cloud, that I write the patient's name so I can recognize it. They're in date of the surgery, CPT code, the RVUs with it. So I actually learned what RVUs are attached to CPTs, and their procedure category, so I can organize things very quickly if I want to look at all my Crohn's cases, and comments about the case I want to remember, and any complications. So it's obviously great if you're giving a talk on Crohn's, you type Crohn's or organize by category by Crohn's, you see all your Crohn's cases. It teaches you the CPT codes, and you have to do this if you want to get a fellow American College of Surgeons right for the 1 year log. But I actually, it helped me a lot in building my confidence because of this complication tab. So when I did have a leak, I could look at this and scroll through and look at all the cases where I didn't have a leak. And it can be tough at the beginning, right? We only have like 9 rows. These are actually my first few cases, the very first few cases I did. So contained leak in a gram patch anyway. But you don't have a big N so far, but I found it very beneficial for my practice and still do. Some of you may start pumping out like 10, 12,000 RVUs and may not be able to do this for your practice, but I've appreciated it. I do around 7,000 RVUs and still able to do these. When I put them in is when I get my billing note and operative note to read for the dictation, because that gives me the assigned CPT code that I can double check. Adopting new things, just a word on the OR. So yes, you may start doing new things. Like when I came in, I was doing ileocectomy. I did an end-to-side anastomosis, and when I was putting the EA through the end of the ascending colon, the whole OR staff was looking at me like, what is going on? And of course, the patient did fine. I've done it a few more times, and they finally accept it. It's like, that's a standard anastomosis for this. Because nobody at UAB was doing it previously. So it was sort of weird for them to see. Halfway into my practice in first year, I realized that my patient population is very different when I trained in, and that trained in fellowship. And I like these big male obese narrow pelvises. Like I couldn't do it laparoscopically like I wanted to for speed, or and so I really needed to get back on the robot. So I actually went back and like redid the little refresher training with Da Vinci and got back on the machine, and that was good. And then I mentioned about ventral mesh rectopexy. I came out of fellowship a big believer in ventral mesh rectopexy, but nobody of the 7 partners that I had at UAB was doing it. So, but I didn't really come out like guns blazing, like this is going to be my treatment for rectal prolapse in everybody. I sort of stuck with what the rest of the people were doing in practice, doing a few suture rectopexies. And I finally found a case that absolutely needed it. It's like a vague interstitial recurrent rectal prolapse. And so I worked with my guidance and ended up doing a combo procedure, and have since really picked it up more. But I think that's just to be mindful, like, what are you going to be bringing new? When is the right time to introduce those new procedures? Do you want to develop a little bit of street cred and doing the same thing that everybody else is, similar ways to what other people are doing? It's a balancing act. All right, building your referral base in 3 quick steps. Yeah, go ahead.
Quick question about, so just what you were just saying. So
Yeah.
because you did your residency at UAB and then you went away for fellowship, you came back, how, like in terms of not rocking the boat, like how did you come back and we're like, hey, I'm an attending now, like I'm no longer a resident, and kind of balance that with trying to still be as helpful as you can as the like most junior partner?
I think once you complete your first few cases and like discharge them from the hospital, that like separation between like I was a resident, now I'm a attending, like it's completely gone. Like, look, I can successfully manage somebody, like test proven, but we'll go onward. But there was a little bit of practice patterns, and particularly around doing VMRs with mesh, because like I'm knocking on wood, I haven't had one of the big mesh complications probably yet in my career. But I was worried about that, like bringing in a new procedure, having a complication. So, and CBJ knows this, when I do these cases, I'm still a little bit earlier on my volume, and I'm very hands-on with those cases, just trying to ensure optimal outcomes. So that was something careful to navigate.
And at a teaching institution too. So I mean, like one thing that I've said is like, I don't need the fellow. Don't send me the fellow my first year of practice, because I need to do these cases. How did you manage that at a training institution, kind of needing to do everything but still having to teach?
Yeah, it's something I am still constantly trying to learn. The robot was very helpful for me because first year I was getting mainly PGY3s and doing these difficult LARs. Like I needed to be able to take control while I'm in the pelvis. And the robot enabled me to do that. I need to get the case done. It's very hard laparoscopically or open to tell people where to bovie, the fellow is a little bit easier because I know your goal at the end is to be able to do everything. But it's tougher with like the PGY3 and PGY4 to me. It's like what steps of the operation. So using the SAGES mentality of teach the teacher course, I've been trying to be a little bit more practice, saying like, what part of the case do you want to do? And like giving them a lot of time to do that. Maybe it's the lateral to medial or medial lateral dissection. And then saying for the rest of it, I got to get it done because we got to get on to the next case. So.
And then when you're booking cases with your OR times, did they just take the average of your partners, or did you kind of come in with an idea of being like, I need 4 hours for this case?
Good question. I have no idea how they come up with the OR times. I literally just book things that I think are reasonable in time, because I don't know that they have a good system for putting the right times on the board. We do run 2 ORs at UAB. My first few cases, I tried to avoid that just so that I could learn the culture and be safe. But quickly, within 3 months, there's a little bit of clinical pressure to like, oh yeah, I can run an anorectal rim simultaneously, and that's fine. And then later on, when you do have access to a fellow, you can start booking 2 cases, adjacent. So we'll go on to building your referral base in 3 steps. The first thing that will help you build your referral base is being a nice person on call. So you're gonna get calls from people, GI, and people at your institution. You may get calls from people at other institutions. And I think it's great to say, like, hey, I'm one of the newer colorectal surgeons here. I just want to introduce myself. Can I get your cell phone number and send you my contact so we can be in touch either about this patient or other patients in the future? And then doing what you've learned all these years of just taking good care of patients, being timely and responsive, responding to pages appropriately. And then I also found if I got a referral from an outside hospital while I was on call, I provided an update like, hey, so-and-so came in with fulminant ulcerative colitis. We did a total abdominoplectomy, endostomy. I'm going to see them back in 4 months and reassess them for the next stage. I think that was very helpful. And then if you're an Apple user, creating one of these, whatever the cards, and to send that. So if you scroll down on this, I can't do it on this screen, but it's got my office address and additional contacts. And I don't share a card, like a business card. Only patients really ask for that. I share this contact with people, and because they want to be able to text me when they have a problem or issue or call me. So that's my business card. Second step, practice good communication skills. So on your notes, making sure with your electronic medical record, how can you make sure your notes are going out to your referring providers? We have an auto fax system using Cerner that actually is pretty reliable. And I write my notes where the plan and the summary is right there on top. So referring providers can recognize my notes and get the care plans they need quickly. I was given this tip by John Porterfield at UAB to send pictures of your specimens. Referring providers not only love it, because then they have a picture they can add to their database, but they also establishes like a connection between you and them. They remember you, like, oh yeah, this guy sent me that big old mass. So here's a text from a GI in an outside town. I sent him a picture of a colon cancer. Said, great, I don't get to see it from that side. Thanks for your help. Hopefully you got it all. And then lastly, being available for these referring providers. Whatever you are, there to be rural towns that need help, and you may be on vacation at a kid's birthday party, and they may text you and say, hey, I got an issue. It doesn't take you 5, 7, 8 minutes to talk to them, figure out what their problem is, and connect them to the right resources. I mean, I'm not going to leave my kid's birthday party, but I will connect them with my partner who's on call and make sure they get those resources for those patients. So.
Quick thing, a plug for the photos of specimens. I've been doing this with the GI fellows for like patients that we share consults on, and the fellows love it. And it's something that I'm going to totally keep doing. I think it's a really cool thing, and the GI docs especially really appreciate it.
No, it's great to build your own picture database too for any talks you're asked to give later on. So it's good to think in your OR, like, how do I keep this case going, but get that picture later on? So another tip. All right, step 3. I think step 1 and 2 are probably the most important for getting the referring, like doing good work, being a good communicator is probably most important. But I've also gotten referrals from engaging with the community. I participate in our Crohn's Colitis Foundation here, their education day, their Take Steps, and many of their other efforts. We have a local colorectal cancer foundation and we participate in their run. I've gotten calls from just giving a talk on a CME course for GI medicine. And I'll be honest, I have not actually gone to any GI or oncology clinics. We're going to one soon that we already have a relationship with just to validate that relationship. But if you walk in and don't have any proof of your work, it's hard for them to remember you. So I think, again, step 1 and step 2 are most important. So, all right, I'm going to transition. We're at 6:40 for just a few tips in academic practice and then a few more tips after that. So for people that are going to academics, you may find yourself in one of these categories of your commitment from 20 to 70% or more or less either way. And it's important to know your split because that's what's expected of you. It should be outlined pretty clearly in your contract. Some people may have, goals for each year. I had goals for grant submissions each of my first 3 years that had a contingency of my supplemental research funding. And then, of course, your focus may completely vary by whether it's on research or education or in service for some of these examples. So that's all unique to each person. It is important, though, while you may have had interest to really figure out, like, what are my local resources? Where is the strength of my institution, and how can I align with that strength? Most institutions have like a strategic plan that they publish online, and they have priorities that they have outlined. So can you find those? What cores and resources align with your research available? Of course, what mentors? And then for people that are into research, what grants are available internally that you can quickly be seeking after to try to establish a groundwork on your projects. Things like a KL2, a 2-year award. It's a stepping stone towards a 3-year K award from the NIH after that, or other pilot awards. I'll share my experience just because the academics get so variable, but I just want you to know this hard and it takes a lot of perseverance. This is so first year, September 2020, right after COVID, starting out. I came out of fellowship with this big passion for improving outcomes for patients with a ostomy, and particularly for people with low health literacy. Is a strength of our institution. We have a lot of low health literacy people in Alabama. And so we have these 3 great aims on this project. And I actually spent part of the 4 weeks before starting helping fine tune some of these aims, and wrote a KL2, that 2-year award that I was really hoping to get. And they wrote back saying, good science, good mentorship team, we're not going to fund it. So I quickly reformatted it for a palliative care grant, and then for a SSAT Career Development Award, for the NCCN Young Investigators Award, American Surgical Association. Everybody was saying, great science, good team, but not our priority. And a lot of it was like, ostomy care is not that sexy of a topic. So I actually took the aims to the Association for Academic Surgeons. They had a career development course. I sat down and showed my aims to Justin Demick. And his advice started out with, if you choose to continue this research focus, and then he went on to more details. And so I took those first few words as like, okay, Bob, if you want to get a career development award, you got to change your focus. So then I sat down and completely changed and aligned even more with my clinical practice and my institutional resources. That was part of the Institute for Cancer Outcomes and Survivorship. We have a huge focus on inequities, and I had all this experience with hereditary colorectal cancer from Cleveland and from my practice at UAB, and thus started out on a new track. And I'll show the next slide. So how did that play out over years 2 through 4? We ended up 2022. I handed all the ostomy research to one of my research residents, Hannah Sheffer. She reformatted it and got it funded. So actually, a lot of that work's actually gotten done under a resident research award. We've gotten clinical grants, this ADPH award for colonoscopy screening in vulnerable populations, HSF, another internal award to get a registry started. I partnered with other scientists here at UAB doing like time-restricted eating and rectal cancer patients undergoing neoadjuvant therapy. So that's been really cool to partner with nutrition here at UAB. It's not my project, I'm just a co-investigator. But it wasn't until 2023 October, so 3.5 years later, that I finally submitted a KOA to the National Cancer Institute. We got a pretty decent score. We're actually still waiting to hear finally if it's going to get funded, and we just submitted a resubmission of the KOA while we're waiting to hear to get funded last week. So more to come on that. Do you have something you wanted to ask, Steve?
Yes, but not quite related to this. I was going to see what you're going to do next.
Yeah.
Yeah.
This was a step. This just came out from American Journal of Surgery about developing career development award. There's a quick 2-page read from Andrea from the group in Michigan about, who do you want to be if you want to be a scientist? What skills do you need? Who can teach you those skills? And then what questions and developing that career development award. And then important to know, also ASCRS has a lot of resources, so stay engaged. And then, of course, they have the Career Development Award. They have another Limited Project Award from the Research Foundation. And then they have CREATE. So if there's any surgeon scientists on the call that don't know about CREATE, it is, I think they meet monthly. I could be wrong on that, to review like specific aims pages or grants. And they get input from a variety of colorectal surgeons with academic expertise. I showed my specific aims for my K-weight on there. It's hugely impactful in redirecting my K-weight in a more fundable direction. So definitely check it out. You can observe, watch, learn, and then contribute when you have different things to offer. And then for those also on the academic track, know that you will have to apply to tenure at some point. A variety of stipulations at different institutions. I was given advice to keep this Excel to track everything I do. So this lecture will go onto this education slide, and I've been putting every small little education thing I've done. Service is like all the committees I've served on, the grants, abstracts, and mentees that have been participating with us. So this is really important. And it'll hopefully make that tenure application a lot easier.
How do you choose what goes in those tabs versus what you put on your CV?
Oh yeah, this is a lot more exhaustive. And my CV has a sort of a basic format from publications and stuff. So yeah, I keep a running list of both, and I keep both updated. But this is much more detailed than the CV.
Okay. And then a couple questions for you. So one, just we would love to hear like your thoughts or your perspective on social media presence and the importance of that for all of us about to start our first real jobs here. And if you have any advice for dealing with patient reviews online.
Ooh, good questions. Social media has been more about engagement with the society and other physicians for me. And also knowing like what's going on in the field, what are the hot topics, I love logging on to Facebook, seeing the Ask Ours discussions about different cases. But I've less engaged as a mechanism to get referrals. And in terms of like patient reviews, yeah, I know I have a website that can get patient reviews anonymously added to it. I've never had to handle any, fortunately. I think there's a few bad ones out there. I see them sometimes come through, but I don't know what my institution does with them, to be honest. I don't really look that hard. I just keep on chugging along.
Yeah, I feel like that's one way. Just you have to deal with so much like as you're first starting that trying to find those reviews. I think if they come to me, great. And then is there something that you knew in year one that you know now? Like if you could tell past Bob, first year attending Bob, if you could tell him one thing, what would it be?
Actually, it probably two things like clinically. One was actually when I was speaking about my nurse coordinator. I've actually had 3 nurse coordinators over 4 years. And I think developing a really good relationship with them was so important. You see senior surgeons that have those nurse coordinators who can like run a practice, right? And I think I failed to mature that relationship at the speed that it should have gone. So I was doing a lot more work than I probably should have. So that was one thing. It's really investing in that relationship, telling them, what I had told patients, as I mentioned earlier. And then clinically, obviously it took me 6 months to hop on the robot, so I wish I'd done that a little bit earlier. but that's a minor thing.
And what was it like when you admitted your first patient and you saw your name as the attending?
Yeah, it was sort of weird because they put my full name on the chart as Robert Hayne Hollis IV and all my initials, MD, MSPH. So I actually got a lot of text about how ridiculous that is. They put my full name on there. But yeah, you feel that sense of ownership and responsibility, which is, like, wow, yeah, I'm the person they're going to call. But once you get more reps, it just becomes really your normal practice. And this is a side note, but I personally, CBJ knows this, I like to get phone calls about all my patients every day of the week. It's easier for me to communicate. I'm not a big fan of making the residents text me unless I'm like in a meeting. So I can educate better through a phone call, and I can ask questions, and so I know what's going on. So I actually found that really beneficial and doesn't seem to be causing too much stress.
Yeah. Is that something that you knew from day one? You're like, I'm going to be the attending that needs to have a phone call no matter what.
I asked for it because I knew it would off burden some of the residents, and I had two attendings in my training that did it. I remember more from them from their phone calls than any text message I ever received.
Yeah.
I'll
Yeah. Oh,
briefly say
this was going for the next, this was going to answer the next question. This is
how to say it. Yeah. So this is just an example right here of saying yes. So 4 months, 4 weeks before I started. So so I had just finished fellowship, so it was probably a weekend to my time before starting. I got a call from my division director that said there's these hospitals in Alabama that are shutting down. UAB's offered to help manage them, but their general surgeon's gone, and we need to offer general surgery coverage. And it's on the Division of GI Surgery to do that. And so he asked me, will you be willing to go to one of these rural hospitals for 4 days out of the month and provide general surgery coverage? I was envisioning, leaving Cleveland, like having a complete colorectal surgery practice at UAB. And quickly things changed. So this is a hospital that I went to in Demopolis, Alabama. It's 2 hours away. And I went there and spent 4 days living in the hospital. And I learned so much from saying yes in this bit of a stretch ask, right? It forced me to like go back to a lot of general surgery stuff, doing lat choles, which I thought I wasn't ever going to do again, putting in metaports and also learning how to serve vulnerable patients in limited resource settings. Since then, we've been able to develop a whole research network at these rural hospitals, and it's given us a unique leverage for our research that few other places have. So sometimes when the yes is something that you're not too excited about, it can really open up some doors. As I've gotten to my 4th year now, my list of commitments is pretty high. And I have said no to things, especially when I have pressure on me to get a KO8 funded, right? I can say no, saying I have to get this funded or my career direction is going to change. And so that's when leverage to say no later on. But yes, I did say yes pretty often early on. And that gets on to this last thing that I have. That is the last slide I have about my expectation. I meet with my chair, my division director, pretty much yearly, and we go over. The chair only asks one question is like, what, or two questions. What is your 3 goals for next year, and what were your 3 goals for last year, and what happened with them? And so these are, I go to those meetings prepared. I have slides that dictate like everything that I have going on. Because if you ask me right now, I couldn't tell you everything. I'll just forget it. And then I have those goals sort of outlined going forward. And then this last thing I have was like summary, is to recognize that y'all are like 2 weeks away from like be done, and it's awesome and you need to celebrate it. Remember that you're going to get settled, you're going to make contacts when you get going, you're going to build that framework. I would prepare for clinic, learn your local culture, meet your OR team, learn your resources, know who your backup is, and then develop this overarching strategy for your career as a start of how you want things to begin. So this is a picture of all of me and some of our co-fellows. Remember, you're going to reunite at ASCRS and keep the text chains going. We still have a WhatsApp group who meets all the or talks all the time about different procedures, and so that's great. Anyway, I'll let you ask what other questions have.
Thank you so much. That was awesome. A lot of positive feedback in our WhatsApp, actually, which I also hope we keep forever. Let me just see if I missed any here. But so when you're meeting with some of the stakeholders, like meeting with GI and meeting with ONC and trying to figure out what the culture is, was there a time that you found out that maybe you were like stepping on somebody's turf or stepping on somebody's toes, like over, like, let's say colonoscopies or something? And then if so, how did you deal with it?
I certainly met with people who refer to other providers. I met with one of our big IVD guys, and he primarily referred to 2 of our other colorectal surgeons. I have a good relationship with him, but I didn't really get many referrals after we met, and that's fine. So that'll happen, and people just follow practice patterns. one of my good friends from growing up in a small town in Alabama, his dad is one of the big GIs of the group. And I thought he would definitely send me like some referrals. He still sends them all to my partner. So don't have your feelings hurt. People just learn these trust in relationships, and that's okay. And then in terms of I don't think there's too much shortage of endoscopy screening, so I haven't really upset too many people. Oncologists are important to communicate with the community, to know that if they send you a patient, that you're not going to steal all of them and send to oncology at your institution. So keeping those lines of communication clear are important. I think those are probably the biggest turf navigation that I've done.
And then do you feel like you were seeing patients more frequently in terms of like return visits, or like I'll see you in another 6 weeks when you first started? And then how did you kind of transition your follow-up periods, if you did at all?
Yeah, I think I saw everybody at like 2 to 3 weeks first, and they're like still in pain, still having issues. So I'm more of a 4-week person. To be honest, I've gone to complete virtual follow-up for all my patients because people know they're having problems. They know their wounds are having issues. And that's been great. And to be honest, I only have a half day of clinic a month, and I've got 20 patients tomorrow morning. Yeah. So I've really depended on my nurse practitioner now to see most of my post-ops. So, but yeah, at first you hang on to people and you want to know how they're doing. Sometimes on your case log, you'll go back, and say like, I wonder how this person's doing, but at some point you get so busy that you just keep chugging forward.
And I know, I mean, all of us, like you're saying, you see patients in the morning, you see patients in the afternoon. Do you feel like it was hard to kind of transition from like that chief mindset, that fellow mindset of like, I need to make sure I know like every little detail, and kind of now like letting the residents tell you like what's going on with your patients and kind of developing that trust? Like, how did you go about doing that? Or is it really just time?
Yeah. But one thing I never did was put in orders. And so
yes,
that was a good barrier for me to like rely on residents and communicate well with them about what's going on. I still check the chart. Yeah. I mean, to be honest with you, when you're first collecting me in anastomosis, you're going to be checking the vital signs every 4 hours to know what's going on. So I still check things, and then I'll ultimately get busy and you check last. And then something will happen. You'll have a complication. You're like back in the game, like looking at everything. It's sort of ebbs and flows of that. But I think the orders thing has been good. I've been intending to put an order in the past and well favored over. So
it's a good boundary. Well, I don't think there are any other questions in the chat or on Surgeon, and it is 7:00 for us now. So thank you so much for being here. We really, really appreciate it. This was a great talk, and I know we're looking forward to more in the future, and you'll be looking forward to many phone calls from me, I know. But yeah, thank you again. And then to everybody watching, remember to subscribe if you're not already subscribed to our talks. And in a couple of weeks, we'll have a whole new leadership crew for you too. So transitions kind of all around, and congrats to all the fellows out there that are almost done. Thank you again, Dr. Hollis. I hope you have a good rest of your night, and I will see you tomorrow.